You're ready.
For demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The American Heart Association's systematic approach includes 3 components once you have established scene safety and your initial impression of the patient: the BLS assessment, the primary assessment, and the secondary assessment. These sequences combine assessment and treatment components for effective resuscitation. When deciding which assessment to use for a patient, start with a step we all do automatically. Visually assess if the patient is conscious or unconscious. This is your initial impression of the patient. You can form a rapid general impression by a quick visual assessment of responsiveness, breathing, and color to determine the urgency of the situation. After determining that the scene is safe, if the patient appears unconscious, use the BLS assessment. After completing all of the appropriate steps of the BLS assessment, progress to the primary assessment for more advanced assessment and treatment. Finally, progress to the secondary assessment. If the patient is conscious, go directly to the primary assessment and then the secondary assessment, which we'll review in a moment. For unconscious patients, you'll follow the BLS assessment. First, check for responsiveness. Tap and shout.
Are you okay?
If the patient is unresponsive, shout for help.
He's unresponsive, I need help?
Activate the emergency response system and get an AED or defibrillator. Depending on the circumstances, EMS providers may need to call for additional responders to assist with the patient. In some settings, the healthcare provider may assess the patient's breathing and pulse before activating the emergency response system. Next, check breathing. Scan the chest to detect if breathing is absent or abnormal. Check for pulse. Ideally, you should check breathing and pulse simultaneously. If you can't feel a pulse within 10 seconds, start high-quality CPR, beginning with compressions. If you determine the patient is not breathing normally, but definitely has a pulse, bypass chest compressions and support the patient by ventilating once every 6 seconds. As soon as possible, attach an AED or defibrillator and, if indicated, deliver a shock. High-quality BLS is the foundation for saving lives after cardiac arrest. If these steps are performed rapidly and well, the patient's chance of survival increases. In fact, the effectiveness of advanced life support measures depends on high-quality BLS. In some cases, BLS will result in ROSC, but sometimes cardiac arrest persists, requiring you to continue with more advanced invasive measures. This is when you should follow the primary assessment and secondary assessment. Another time to use the primary and secondary assessments is if a patient is conscious. You can easily remember the steps of the primary assessment by thinking A, B, C, D, E. Keep in mind that although these steps are listed in progressive order, the resuscitation team often performs them simultaneously. A stands for airway. For unconscious patients, healthcare providers should maintain a patent airway and consider inserting an advanced airway device. Regardless of the device chosen, the resuscitation team must ensure proper placement and use waveform capnography to monitor effectiveness. Conscious patients can often maintain the integrity of their own airway, and healthcare providers need only ensure patency by providing suctioning if needed. B represents breathing. If the patient is not in cardiac arrest, healthcare providers should assist ventilation as needed once every 6 seconds. If the patient does not require assisted ventilation, healthcare providers can support the patient by administering oxygen as needed. C involves supporting the patient's circulation. Attach ECG leads, obtain intravenous or IV access, or intraosseous or IO access, give appropriate drugs to manage abnormal rhythms, and assess for perfusion issues. You are collecting a wide range of information, including blood pressure, heart rate, and cardiac rhythm. Additional data, such as temperature and glucose levels, may further refine the initial interventions needed. The A, B, and C steps provide a continuous stream of information about the progression of the patient's condition. D stands for disability. This involves checking for neurological function, quickly assess for responsiveness, levels of consciousness, and pupil dilation. A quick tool that can be used to evaluate neurological status is ABPU, alert, voice, painful, and unresponsive. Finally, E involves exposing the patient. Remove clothing to perform a physical examination, looking for obvious signs of trauma, bleeding, burns, unusual markings, or medical alert bracelets. The secondary assessment involves the differential diagnosis. This involves obtaining a focused medical history and searching for and treating reversible causes. You may naturally jump to some possible diagnoses as soon as you evaluate the patient. However, before arriving at a definitive diagnosis, you'll need to assess the patient and gather additional information about the condition. Gathering a focused history of the patient is recommended. Ask specific questions related to the patient's presentation. Consider using the memory aid sample, signs and symptoms, allergies, medications, including the last dose taken, past medical history, especially relating to the current illness, last meal consumed, and events, especially ones that may have led up to the current illness. The answers to these questions can help you quickly rule in or rule out suspected diagnoses. Next, look for and treat the underlying cause by considering the H's and T's to ensure you are not overlooking a dangerous or likely possibility. The H's and T's create a roadmap for possible diagnoses and interventions for your patient. Let's review these now. Hypovolemia is low blood volume. Hypoxia occurs when inadequate oxygen is reaching the body's tissues. Hydrogen ion or acidosis is the accumulation of acid and hydrogen ions in the blood and body tissues. Hyperkalemia is an abnormally high concentration of potassium ions in the blood. Hypokalemia is low blood potassium. Hypothermia is when the body temperature drops below 95 degrees Fahrenheit or 35 degrees Celsius. Tension pneumothorax results from an abnormal accumulation of air in the pleural space. Cardiac tamponade is a condition caused by an accumulation of fluid between the heart and the pericardium. Toxins may be best uncovered by a focused history. A pulmonary thrombosis or pulmonary embolism is a blood clot from a large vein that breaks off and travels to the pulmonary artery where it becomes lodged. A coronary thrombosis is a blood clot that forms within a blood vessel of the coronary system. Intervening and stopping a patient's downward spiral is the ultimate goal of the BLS, primary and secondary assessments. The American Heart Association has developed a truly systematic approach that can facilitate optimal care. By following the assessments in tandem with an adherence to the chain of survival, you will more efficiently and effectively assess, diagnose, and treat your patients.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, The healthcare providers in this video do not always use personal protective equipment, such as gloves. The following information represents American Heart Association guidelines and best practices for measuring and improving the basic life support skills of the teams you work with. The successful resuscitation of a patient in cardiac arrest requires a coordinated team effort. Effective teams have providers with well-defined roles, and they work together in a dynamic and timely fashion to prioritize and complete critical tasks. The team leader is responsible for coordinating these tasks and ensuring that clinical care is delivered according to American Heart Association guidelines. Delivering high-quality CPR while minimizing pauses optimizes outcomes after cardiac arrest. But because of competing priorities, it can be difficult for team leaders to continuously monitor and provide feedback on CPR quality. The CPR coach is a new role within the resuscitation team, and it's designed to address these difficulties and promote the delivery of high-quality CPR. The presence of a CPR coach allows the team leader to focus on other elements of cardiac arrest care. Whether you are a basic life support provider or an advanced life support provider, the role of CPR coach exists to help you and your team deliver high-quality CPR. The most effective way to implement the role of a CPR coach is with a real-time audio-visual feedback device. We'll discuss some of the functions of the CPR coach and how they use feedback devices. First, let's talk about the team layout when using a CPR coach. CPR coaches should stand across from the compressor, always in the compressor's direct line of sight. CPR coaches should also stand next to the CPR feedback display, which is often located on the defibrillator, so that they can effortlessly redirect the compressor's attention to the data provided by the feedback device. Now that the CPR coach is in place, they should verbalize the data from the feedback device, providing corrective and positive feedback, such as push harder or your rate is good.
Great job. You're right on target.
In addition to giving corrective feedback, CPR coaches should give mid-range targets so that providers can focus on a precise metric. An example of this would be coaching the compressor to target a rate of 110 compressions per minute, taking the average between the recommended range of 100 to 120 compressions per minute.
And now you're too fast. Target for heart rate is 110.
The CPR coach should also coordinate the initiation of CPR and pauses in CPR. These actions can include initiating CPR, placing a CPR board if needed, analyzing the rhythm, switching compressors, defibrillating, or intubating the patient. The goal of the coach is to keep all pauses to 5 seconds or less when possible.
Switch.
Okay, Nadia, go ahead and
Hover.
start. And shock.
Clear. Shock.
Resume.
Except for intubation. Intubation should be performed by skilled providers, ideally without stopping compressions.
Okay, through the cords.
But if it's necessary to pause for intubation, the pause must be for 10 seconds or less.
Still having trouble. Go ahead and pause CPR. Okay, there we go. Through the cords. Continue.
If intubation can't be accomplished in 10 seconds or less, the team should continue compressions with bag mask ventilation. Being an effective CPR coach takes practice and training. If you'd like to learn more about how you can incorporate the CPR coach role into your resuscitation team, please ask your instructor for more information.
All right, here's when we got to do CPR. But anyway, listen up. I have put a cardiology practice exam in here for y'all, and it is open as of right now, and it will be open till the 8th. It's 249 questions. Okay, it is not a timed event, but you need to go in and answer all these questions on this because it is an exam test and it is a grade. But I will tell you that the final exam are pulled out of these questions. Okay? So, I'm trying to help you all I can.
How many attempts did we do?
2 attempts. Okay? The reason I don't have a time down there, if you want to use your book and open up and go through, it's fine. Okay? You should be able to go in and out of it. Okay? I wouldn't try to do it at work though. Huh?
You said it took until 8?
To the 8th at the 8th at midnight, which is next Tuesday. Before y'all come back Wednesday, okay? Because next Wednesday you got your ACLS exam and the testing. And then Thursday you got your final cardiology. Okay? So that's why I'm giving you this test is to help you, not hurt you. Your test questions for your final cardiology exam are pulled out of these 249 questions. Okay? Any questions on this? Let's carry on. One of us tell you who OWN is.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The foundation for resuscitation of cardiac arrest patients is high-quality basic life support. It's critical that you successfully perform these skills because effective advanced cardiovascular life support depends on it. These skills help save lives. High-quality CPR maintains blood flow to vital organs, especially the heart and brain. The components of high-quality CPR include adequate compression depth. Remember to push hard, compressing at a depth of at least 2 inches.
Remember that?
Make sure you position your body over the patient. Good body position, with the shoulders serving as the fulcrum over the chest, will help you use your own body weight to perform compressions. Consider a step stool if necessary to achieve this position. If the person is not on a firm, flat surface, consider inserting a short board beneath them. Adequate compression rate. It is important to push fast by compressing at a rate of 100 to 120 compressions per minute, allowing complete chest reflow between compressions, minimizing interruptions in compressions. Healthcare providers must minimize interruptions in chest compressions. This includes any pauses to deliver ventilations. When healthcare provider
Sure. That's a short board right there you put up under the chest to do CPR on. That's that's what they call a short board. All right? Thank you. Yeah, show them. That's a short board.
Short board kit. Let me come on. You see it?
It gives you a hard surface when you're doing CPR.
When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases to
Remember
normal
this portion.
and remains very low until compressions are resumed. It takes several compressions to build enough pressure to achieve an adequate coronary perfusion pressure necessary to get lost. And finally, avoiding excessive ventilation. The AHA requires the use of audio-visual feedback and prompts devices during a training practice and testing and highly recommends use during real emergencies for real-time monitoring of CPR quality. The first skill we'll demonstrate is performing continuous chest compressions for 2 minutes.
Any discussion? Coronary perfusion pressure takes a long time to get back. That's why you want to limit your stopping to 10 seconds. Any questions?
Chest compression fraction.
Yes.
Compression time over the cold.
So, let's build on.
Go ahead.
Chest compression fraction was the time of compression over the total cold time, right?
I didn't hear you, brother.
The CCF,
Yes?
compression time over the total cold time, right?
Correct.
So, let's build on these skills. We'll now illustrate 2 healthcare providers assessing and performing high-quality BLS, including the use of an AED.
Is the scene is safe? Are you okay? Are you okay? We need more help. Call for backup and bring the VFib. No pulse. He's not breathing.
Rachel.
Attach pads to patient's bare chest. Plug in pad connector. Analyzing heart
Clear.
rhythm. Do not
What?
touch the patient. Shock needed. Charging.
Right here.
Stay clear of patient.
Clear.
Shock now. Shock delivered.
In summary, perform high-quality CPR by compressing at a depth of at least 2 inches and at a rate of 100 to 120 per minute, allowing complete chest recoil, minimizing interruptions in compressions, and avoiding excessive ventilation. Additional measures, such as switching compressors every 2 minutes or earlier if fatigued, and using an audio-visual feedback device to improve CPR quality in real time, will help give patients the best chance for survival.
Right. Been a while
Products
since
are
y'all done
shown for
airway.
demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart. So it lowers cardiac output and the patient's chance of survival. Tidal volumes should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half the squeeze of an adult ventilation bag. Let's begin with basic airway skills. The first two steps in any airway management response involve opening and clearing the airway. First, open the airway by using a head tilt chin lift maneuver. Place one hand on the forehead and one on the chin, and push with your palm on the forehead to tilt the head back while lifting the jaw to bring the chin forward. This simple maneuver lifts the tongue from the back of the throat, opening the airway. This procedure is typically performed on patients without any evidence of head or neck trauma. In patients with suspected cervical trauma, a jaw thrust without head extension is used. In a jaw thrust maneuver, place your fingers just under the angles of the lower jaw and lift with both hands, displacing the jaw forward. If the jaw thrust does not open the airway, use the head tilt chin lift, because maintaining a patent airway is a priority. The second step is to clear the airway. Providers should suction the airway immediately if there are copious secretions, blood, vomit, or a foreign body. Use a large bore, non-kinking suction tubing and a large suction catheter with a rigid pharyngeal tip. High suction pressure may be required. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are two types of airway adjuncts, the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use disposable plastic device. OPAs are available in various sizes, with the most common adult size ranging from 8 to 10. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. To use the adjunct, insert the OPA so that it curves upward, with the tip pointing to the hard palate. As the OPA passes through the oral cavity and approaches the posterior wall of the pharynx, rotate it 180 degrees into the proper position. Alternatively, the airway can be inserted sideways and rotated 90 degrees into place. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. OPAs that are too large may obstruct the larynx or cause trauma to the laryngeal structures. OPAs that are too small or inserted improperly may push the base of the tongue posteriorly and obstruct the airway. Healthcare providers should insert the OPA carefully to avoid soft tissue trauma to the lips and tongue. Remember to use OPAs only in unresponsive patients with no cough or gag reflex. If the patient has a cough or gag reflex, The OPA may stimulate vomiting and laryngeal spasm. Only healthcare providers trained in the proper use of an OPA should attempt its insertion. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. Before inserting an NPA, lubricate the airway with a water-soluble lubricant or anesthetic jelly. Insert the NPA through the nostril in a posterior direction perpendicular to the plane of the face. Using moderate pressure and a gentle spiral motion, push the device into the nostril. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. If you encounter resistance during insertion, gently withdraw the NPA a centimeter or so, slightly rotate it, and gently try to insert it again. If you continue to encounter resistance, withdraw the airway completely. You may try inserting it in the other nostril. Use caution when inserting the NPA in patients with severe head or facial trauma because of the risk of misplacement into the cranial cavity. With a known basal skull fracture, an oral airway is preferred. Take care to insert the NPA gently to avoid complications such as tissue injury or bleeding. An NPA may also cause laryngeal spasm and vomiting. An improperly sized NPA may enter the esophagus and cause gastric inflation with active ventilation. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. First, let's look at the device itself. A bag mask device is composed of a self-inflating or flow-inflating bag that is attached to a clear, cone-shaped face mask that covers the patient's nose and mouth. The edge of the mask has an inflatable cushion, enabling a tight seal around the nose and mouth when the provider applies pressure to the mask and lifts the jaw. Now, let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the three remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask, and maintaining a jaw lift to open the airway, the provider should squeeze the bag, taking about 1 second to deliver one breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the two-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the three remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag, enough to cause visible chest rise. When using a bag mask device, whether there are two providers delivering breaths or just one, be careful not to press too hard on the mask, which could push the patient's jaw down and obstruct the airway. The American American Heart Association recommends using waveform capnography with a bag mask device to provide increased monitoring of ventilations and CPR quality. Effective ventilation through these airway devices should produce a capnography waveform. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. With careful attention, trained healthcare providers can use an advanced airway to safely provide ventilation that is as effective as bag mask ventilation. Advanced airway devices offer many advantages. These include isolating the airway and reducing the risk of aspiration and gastric insufflation. After inserting an advanced airway during CPR, providers should deliver one breath every 6 seconds without interrupting chest compressions. Unfortunately, insertion of some advanced airway devices, like an endotracheal tube, may require interruptions in chest compressions that last longer than 10 seconds. These interruptions may reduce survival rates for VF arrest patients. It should also be noted that there is no evidence that advanced airway measures improve cardiac arrest survival rates in either in-hospital or out-of-hospital settings. So providers must carefully consider all these factors before performing the intervention. There are other advanced airway devices that healthcare providers can often insert without interrupting chest compressions. These include supraglottic devices such as the laryngeal mask airway, the laryngeal tube, and the esophageal tracheal tube. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. The American Heart Association recommends that you become familiar with a variety of devices, but master one primary method of advanced airway control. If you are unable to establish an advanced airway, continue ventilation with a bag mask device. The laryngeal mask airway is a supraglottic airway device that healthcare providers can insert without visualizing the glottis. In addition, it can be inserted during CPR while chest compressions continue uninterrupted. This makes training easier and insertion more reliable. The laryngeal mask airway is a tube with a distal inflatable cup shaped like a mask that is placed in the patient's hypopharynx. Place the laryngeal mask airway in the open mouth with the opening of the mask facing the patient's tongue. Advance the device to the back of the tongue. In a smooth motion, use your index finger to press the laryngeal mask airway against the roof of the mouth.
What happened? You got something? Yeah, glucose tabs. No, it's just made for